Hello, I'm Mallie Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Gary Glassman. In our CE webinar today, we'll be exploring evidence-based research on sealing the root canal system with respect to obturation in 3 dimensions and restoration of the endodontically treated tooth. Focus will be on the continuous wave of condensation. Upon completion of this CE webinar, the attendees will be able to understand the objectives of endodontic obturation, become familiar with the continuous wave of condensation, implement the continuous wave of condensation in your practice, and understand the importance of post-endodontic restoration. Before we get started, I'd like to invite viewers to use the question box in your control panel to ask any questions. Your questions will be answered at the end of the session. Also, associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees instruction on how to access the CE quiz. Or if you're seeing a recorded version, you can access the quiz on our landing page. I'm pleased to introduce our guest for today, Dr. Gary Glassman. Gary has a private practice limited to endodontics in Toronto, Ontario, Canada. He's a 1984 graduate of the University of Toronto Faculty of Dentistry. He was awarded the James B. Wilmot Scholarship, the Mosby Scholarship, and the George Hare Endodontics Scholarship for proficiency in endodontics. In 1987, he became a graduate of the endodontology program at Temple University. He's currently a staff member at the University of Toronto Faculty of Dentistry in the Graduate Department of Endodontics and an adjunct professor of dentistry and director of endodontic programming for the University of Technology in Jamaica. He is a fellow of the Royal College of Dentists of Canada, a fellow of the American College of Dentists, an endodontic editor for Oral Health Dental Journal, a faculty chair for DC Institute, and a chief dental officer for Dental Corps Canada. Dr. Glassman, we turn the webinar over to you to learn more about our topic for today.
Okay, we are back. Well, it's great to be here, and thanks, Mallie, for that introduction. Today I'm very excited to be here. It's always nice to be able to review different things and discuss what I feel will provide our patients with the most quality treatment available to establish predictable outcomes and provide our patients with the most optimal care possible. So today we're going to discuss, as Mallie had just introduced, 3-dimensional filling of the root canal system. And it's important to understand that we are dealing with a system, not just 1, 2, 3 root canals, but a branching arborization like a tree-like branch, which we have to clean, we have to debride, and once we've done that, we have to seal it in order to provide a favorable environment for healing. So we're going to be discussing a lot of things today. And in addition, one of my most important subjects that I want to talk about is preventing coronal leakage post-treatment. Now, everything we do with root canal treatment is evidence-based, and we want to go through the science and some scientific studies. And it really depends on the different research that we look at, and we have to be somewhat of a critical evaluator when we look at different studies. We've got to look at the variable types, the statistical tests that are being used, and also the methodology. And is the research that we are looking at being done in a basement of a dental manufacturer who has a vested interest in a particular product, or is it a university-based study? Is it double-blind? Is it non-biased? What's the cohort sample? Is it 25 patients, or is it 1.5 million patients? And once something becomes statistically significant, is it clinically relevant? So these are all things that we have to look at when we look at the different science that's available to us. And today we're going to talk about success, the density of our obturation, whether it adapts, whether it bonds, and of course, preventing coronal leakage. Now, bacteria is, are the main enemy of root canal. And of course, the objective of endodontics is to either prevent and or eliminate apical periodontitis. And vital teeth, of course, we're not dealing with bacteria, so we want to prevent the ingress of them And when we deal with a infected state, we want to make sure that we get rid of any bacteria that are within that root canal system, and any that remain, such as in the dentinal tubules, we want to entomb them within the tubules so they don't come back out into the root canal space and then the periradicular area. So one of the landmark study is Kakahashi and Stanley and Fitzgerald, which used germ-free rats, and they exposed their dental pulps. And in a germ-free environment, they didn't develop any apical periodontitis. But as soon as they introduced bacteria, then that's when things went haywire. That's when apical periodontitis began, and that's what we're trying to eliminate. And of course, if it doesn't exist, we want to prevent it. And that, of course, is the objective of endodontics, and the objective of dentistry is good oral health, eliminate pathology, prevent pathology, and of course, retain the natural dentition wherever we possibly can. Now, the most important part of root canal treatment is debridement, disinfection, removal of the organic substrate, hence the dental pulp, as well as remove any bacteria that remain or are in the root canal system. And everything we do up until our final irrigation protocol is in preparation for that final irrigation protocol. I call that final irrigation protocol the main event, and everything we do afterwards is to protect what we've just debrided, what we've disinfected, namely obturation and the restoration of the endodontically treated tooth. So it's essential that we seal the root canal system, not only prevent tissue fluids from coming back into the root canal space, but more importantly, to prevent them from going into the periradicular tissues and either reinfect or prevent healing from occurring. Now, the objectives, of course, are multifold. We want to make sure that we prevent the percolation of periradicular exudate into the pulp space by way of either the apical foramina or lateral infurcation canals. Prevent percolation of gingival exudate and microorganisms into the pulp space by way of accessory canals, lateral canals, and all those arborizations that we talked about into the gingival sulcus. And to prevent microorganisms left in the canal. Now, we're never able to really remove all bacteria from within the dentinal tubules. You know, even the best of irrigation systems, ultrasonics, sonics, even apical negative pressure are able to get our irrigants maybe 100 micrometers, maybe a little bit more, into the dentinal tubules. And we know that bacteria are, can be in those dentinal tubules up to 400 micrometers, up to 400 microns. A laser light has the ability to get into those dentinal tubules 1,000 microns, but by and large, the general irrigation delivery systems are only able to get about 100 microns. So there may be some bacteria left within the dentinal tubules. So it's up to us with our obturation systems to be able to entomb them within the root canal system and prevent them from flaring up and regrowing and repopulating the root canal space. Now, even the best of root canals and the most well obturated root canal systems, if they're exposed to salivary contamination by either a poorly timed or poorly placed restoration, then that's how good root canals fail, from coronal leakage, and that's what we want to prevent. And those are the objectives of obturation. Now, the most common obturation systems and techniques are cold lateral, where you have cones which are placed with sealer in the root canal space, and not only can you get leakage between the interface of the gutta percha and the root canal wall, but sometimes you can actually get it within the actual cones themselves, as opposed to more vertical, where you have a nice homogeneous seal from orifice right to apex, right to apical terminus. The whole technique is predicated on capturing the maximum cushion of gutta percha in a single wave, where we warm up that gutta percha and condense it vertically. And essentially, we're working in a closed environment. A well-fitted cone with good tug back, as we'll talk about shortly, allows us to provide not only vertical forces, but also lateral forces, getting good adaptation of our gutta percha and sealer on the root canal wall, but also to be able to seal those lateral and accessory canals as well that we've so thoroughly cleaned with our final irrigation protocol. Now, some doctors like to use carrier-based obturators as well. And it's a single wave technique. There's different technologies that are available from different companies, whether it's from Dentsply Sirona or whether it's from Kerr Endodontics. But we have that ability now to be able to soften a carrier-based obturator and in a single wave, place it to length and seal off that root canal system. But tonight, we're going to focus on the continuous wave of condensation, which is the technique that most endodontists use when they obturate their root canal systems. Now, there's many studies, but one of the studies that is very close to my heart is the study done at the University of Toronto between 2003 and 2008 by Dr. Friedman and his group. And the highlights of the study basically show that 86% of all teeth showed strict healing according to the strictest of criteria, where you had complete restitution of the periodontal ligament, where you had absence of symptoms, where you had no mobility, no pocket other than physiological mobility, of course, and the teeth were brought back into function. 86% of those teeth healed according to the strictest of criteria, according to the PAI index, or the periapical index. 95% of those teeth remained asymptomatic and functional. Now, this included those teeth that were healing. So they may have actually, if enough time had passed, got into that other category of complete healing. The absence of apical periodontitis was the most significant predictor of a better outcome. In other words, vital teeth had a higher success rate than non-vital teeth, because we're not dealing with bacteria, of course. But I believe with the new technology that we have, debridement systems, the ability to carry our full-strength sodium hypochlorite safely to working length by way of apical negative pressure, that gap is closing now between the success rate of vital teeth and non-vital teeth. But one of the interesting things that they found that they didn't set out to look at, wasn't one of the parameters of the study, was the obturation technique. And they actually found that warm vertical condensation in 3 of the 4 first studies, they found an 11% increase in success rate of warm vertical over cold lateral. And they found that in one of the studies of the 4 studies, a 16% increase in success rate with warm vertical over cold lateral. Eduardo Akasui, University of Sao Paulo, wanted to quantify the micro leakage of bacterial endotoxins in teeth and extracted teeth that were obturated with either cold lateral or warm vertical, specifically the continuous wave of condensation. And what Dr. Akasui found was that teeth obturated with the continuous wave of condensation showed a statistically significantly less micro leakage of bacterial endotoxins than those that were obturated with lateral condensation. So the proof is in the pudding, and there's lots of studies that will show this, that it's less time consuming. It provides less microbial coronal leakage than lateral compaction. In fact, it adapted better to the grooves and the depressions and all the intricacies of the root canal system than cold lateral compaction. Now, there's lots of different systems. In the interest of fair balance, there's lots of systems that can be used in order to downpack, which we're going to show you today, and then backfill. Touch and Heat by Kerr Endo, System B by Kerr Endo, Alpha and Beta, the downpack and the backfill by B&L, the Calamus by Dentsply Sirona. Of course, there's the Obtura, which everyone's familiar with, and Kerr Endo, which has their Elements Obturation Unit. And the one that I like is the Elements Free. It's cordless. There's a downpack device as well as a backfill device. And that's what we're going to concentrate on today. I like it. It's ergonomically favorable, and it's cordless. And Lord knows we have enough cords in our operatory. That day doesn't go by where I almost trip and fall and hurt myself. So it's cordless. There's a downpack device and a backfill device. The downpack device is nice because, like I said, it's ergonomically favorable. Fits in the palm of your hand quite nicely. You can hold it like a handpiece, and it has a multi-directional activator ring, and a very, very light touch will activate that tip of the heated plugger, and it will activate it for 4 seconds. One of the nice things about it is it has a 4-second automatic shutoff. So when you're first using this technique, you don't end up heating up the dentin for more than a few seconds and end up frying the periodontal ligament, which can happen if you lean on it and have too much heat on the root dentin. So 4-second automatic shut-off is nice. If you want to reactivate it, you remove your finger from the activator ring, and then you redepress it. So it works nicely. You can adjust the heat. You can adjust the heat to 150, 180, and 200 degrees Celsius. And I keep it at about 200 degrees Celsius all the time. And it only really should take a few seconds for your down pack. Now, as I mentioned, the whole technique is predicated on capturing the maximum cushion of gutta percha. And that being said, there are available different tapers and different tip sizes as down pack pluggers. There's a 12, 10, 8, 6 taper, all with a 0.5 millimeter diameter tip size. And there is a 04 tip with a 0.3 millimeter diameter tip size. I like to use the 06 taper, 0.5 millimeter diameter tip size, probably around 95% of the time. In those large canals, I may go to an 08 taper because I don't want to slip around and in between the gutta percha cone and the root canal wall. I want to go right through that mass of gutta percha and provide myself with the good ability to three-dimensionally obturate the root canal system, getting both vertical and lateral forces. Now, the extruder is nice, also very similar in handling with the down pack device. It accommodates disposable, single-use cartridges of gutta percha, which we'll discuss in a moment. There is an internally built-in piston. When the activator button is pushed, it will advance automatically to these preloaded cartridges of gutta percha, single use only, and they contain enough gutta percha in order to fill an average 4-canal molar. Now, there's 3 viscosities of gutta percha. There's heavy body, regular flow, and also easy flow. And there's different gauges of needle sizes. There's a 20 gauge, a 23, and a 25. I use a 23 gauge needle, heavy body, 100% of the time. I just find that the tip size is wonderful. The tip size allows us to seal, I'd say, 100% of the root canals that we work on. And the viscosity of the gutta percha is such that when you start to extrude it, you actually feel yourself backing out of the canal. And when you start condensing the gutta percha, it's not tacky. It doesn't stick to the pluggers. So the ability to pack it, get a good 3-dimensional seal, and have total control in your hands is you're able to do that with the 23 gauge needle and heavy body gutta percha. Now, one thing you may not have thought of, and it's really, really important that you do, is how many of you actually disinfect your gutta percha cones. We spend so much time disinfecting the root canal system. We spend so much time getting down to the apical foramen. We spend so much time shaping it. And then finally getting rid of the biofilm, getting rid of the smear layer, that inorganic, organic layer that's created on the wall of the root canal during instrumentation. What a pity it would be, and what a shame it would be, if now we inoculated the root canal with a contaminated gutta percha cone. So disinfect your gutta percha cones. And one of the studies that had the most impact on me was a study by Dr. Fernandez and his group, where he looked at the success rate of root canal treatment evaluated digitally and evaluated by cone beam, but whether or not disinfected gutta percha cones or non-disinfected gutta percha cones were used, where all the other steps were followed properly, and this was the only parameter that was not followed, whether or not we had disinfected GP or non-disinfected GP. And you can see from the chart how significant it is to disinfect your gutta percha cone prior to obturation. The success rate will depend on it. So when you disinfect your gutta percha cones, it's not if, it's when you disinfect your gutta percha cones, you disinfect them for 1 minute. Whether you decide to use full-strength sodium hypochlorite or whether you decide to use 2% chlorhexidine, 1 minute is enough, because if you soak them for more than 1 minute, then you could end up deteriorating the surface of it, which may damage the gutta percha cone based on the science. And you may actually even increase the elasticity of the gutta percha cone, which can make obturation of curved canals very, very difficult. So 1 minute soak. So the question becomes, what do I soak it in? Do I soak it in full-strength sodium hypochlorite, or do I soak it in 2% chlorhexidine? I went back to the research and I found this series of studies where we looked at the effect of the disinfectant solutions on what's called the FAD, the force of adhesion of root canal sealer on gutta-percha cones. And obviously, the higher the adhesion, the more desirable it is. So what Ferreira did with his group is they looked at just that. They looked at the FAD, the force of adhesion, between root canal sealers and gutta-percha cones when the gutta-percha cones were disinfected in either A, full-strength sodium hypochlorite, or B, 2% chlorhexidine. And what he did was he found, with statistical significance, when you decontaminate your gutta-percha cones with 2% chlorhexidine, it resulted in a higher force of adhesion. So, long explanation for a very short message. Disinfect your gutta-percha cones for 1 minute in 2% chlorhexidine. Use a sterile 2x2 gauze that's soaked in alcohol, wipe off the excess chlorhexidine, let the alcohol evaporate out, and then you're ready to fit your gutta-percha cone. Simple as that. So I'm often asked, is there a difference between root canal sealers? And certainly, as many as endodontists there are as many who use different sealers. But we have to have the requirements for a proper ideal sealer. And we go back to Dr. Glassman, where he looked at the ideal requirements for a sealer. We have to use it easily. It has to be able to not shrink. It has to be impervious to moisture. At least it should be bacteriostatic and not encourage bacterial growth. That's really, really important. It has to have the ability to be able to retreat. It has to be radio-opaque, so we know that it's in there as well. So these are all the requirements for an ideal sealer. And of course, we don't want it to stain tooth structure. We don't want that proverbial dark tooth after we've done root canal treatment. So these are the requirements for the ideal sealer. What kind of sealers are available? Well, the most common sealers that are available are zinc oxide and eugenol sealers. Whether it's Kerr pulp canal sealer, Rickards, Procrasol, tubeless sealer, wax paste, you can get them in single dual syringe delivery systems, or you can mix it up yourself. Calcium hydroxide sealers, one of the most common ones are Seal Apex and calciobiotic root canal sealer, also very common for those that want that sort of extra disinfection within the root canal sealer. There are resin-based sealers such as EndoRes, AH+, which is very popular. And the objective here is not only to adapt, but also to bond to the actual root canal, providing ourselves with that monoblock effect. Very difficult to get that 360 degrees circumferentially, very difficult to get that complete bonding from apex to orifice. Calcium phosphate sealers also. And now what's really taken the endodontic obturation scene by storm is bioactive sealers, calcium silicate sealers, MTA biodentine, which is a Septodont product, of course, MTA Filapex, which is a Angelus product, and bioceramics from Brasser. Very common ones that are being used. Often doctors are using single cone techniques. And you know what? The jury's still out on the long-term success of this, but perhaps this is where the future of endodontic sealers lie. Bioactive, stimulate the body's own system in order to affect healing. So let's look at the technique of a warm vertical technique. First thing we got to do is we got to fit our cones. So we want to choose the appropriate size gutta-percha point. Depending on the system that you've used, often there are system-based gutta-percha cones that will match the last master file that went into the canal. So you pick that cone. Place it to working length, and we want to get that feeling of tug back. Tug back is that resistance to displacement. Now, we're never going to get tug back 360 degrees, but we're probably going to get some point tug back at that apical 1/3, and that's where we want to get our tug back. And then take a confirmatory radiograph to make sure that our gutta-percha cones, our master cones, fit right to working length. And that's very, very important, that we fit them right to working length. And take a radiograph. Fit them into canal 1, 2, and 3. If it's a 3-canal molar or 4-canal molar, take a radiograph and then adjust it as necessary. Now, what I like to do, and this is optional, is I like to use my fine medium gutta percha cone. I call this my get out of jail free card. There are system-based obturation systems that go with the NITI system that you just last used. I use one cone pretty well, I'd say about 95% of the time. Fine medium cones, which have somewhere between an 0.4 and an 0.6 taper, or a medium cone, which has somewhere between an 0.6 and 0.8 taper with a feather tip, and I just cut them back as I need. Now, what I like to do also is to accommodate for the vertical movement of the gutta percha, because remember, we're going to be condensing this vertically. And because we're going to be using sealer and because we're going to be warming up that gutta percha, we will get some vertical movement of that gutta percha to cork that apex. So in order to accommodate for that, I want to remove about 0.5 to 1 millimeter of my apical portion. I fit it to length, and then I cut back 0.5 to 1 millimeter. Why half? Why 1 millimeter? Well, if I've got a really large canal and it happens to be straight, I'm going to get more movement of my gutta percha cone. If it's curved and a little bit thinner, smaller root canal, I'm going to get less vertical movement. So hence the 0.5 and 1 millimeter. I want to accommodate for that vertical movement. I want to keep my gutta percha within the confines of that root canal space. So we fit our cone. We cut back 0.5 to 1 millimeter. Again, that's optional. And then what we want to do when we first start using this technique, and we're novice to this, we want to pre-fit the appropriate down pack plugger, because we want to know where the tip of that plugger contacts dentin. I want to know where this contact point is, also called the binding point. And I want to make sure I know where it is, because when I start condensing through gutta percha, I want to know beforehand when the tip of that plugger is going to contact dentin, because I do not want to incite a vertical root fracture. So we pre-fit our appropriate down pack plugger to its binding point, and then we adjust the rubber stopper to the corresponding occlusal reference point. So when I'm down packing, I'll know exactly how far the tip of my plugger is by virtue of how far my rubber stopper is from the corresponding occlusal reference point. So if my rubber stopper is 2 millimeters coronal to my occlusal reference point, I know the tip of my plugger is 2 millimeters coronal or short of my binding point. Now, how far do I want that plugger to be? Well, I want it to be within 4 millimeters to 7 millimeters of my working length. Gutta percha is a poor conductor of heat. It's a great insulator, but it's a poor conductor of heat. It'll only thermo-soften anywhere between 4 and 7 millimeters from the tip of my heated plugger. So that's why I want to be within that parameter. So we fit our plugger, we fit our gutta percha cone. Now we take some sealer. You don't need a lot. You just want to butter it very lightly at the apical 1/3, at the apical 4 millimeters of the master cone, and seat it very gently to length. You fit the number 1, canal number 2, canal number 3, and canal number 4. I fit all my cones. And then what we do is we sear off our cones with our down pack plugger. Sear off all the cones right at the orifice level. Then with a sterilized stainless steel plugger, I seat the cone and create a little dimple in the coronal aspect of that cone to act as a guide for my down pack plugger. So I sear off the cones, and in canal number 1, I take the large end of the stainless steel plugger, seat the cone, and I will get some vertical movement at this point, and create a little dimple to act as a guide for the down pack plugger. I repeat this with the canal number 2, canal number 3, and then canal number 4 if we have 4 canals. Now, we start our down pack. We activate the down pack plugger, we place it on top of the dimple, and in one single continuous fluid motion, we advance that warm plugger through the mass of gutta percha until my rubber stopper is 2 millimeters above the occlusal reference point. I know when it's 2 millimeters above the occlusal reference point, when my rubber stopper is, that my plugger is 2 millimeters short of the binding point. And I activate it until it's at that point, and then I release my finger from the activation button. And as I do this, I maintain pressure on the down pack plugger, and as the plugger cools, so will the gutta percha not only cool, but harden, and the plugger will slow its apical movement as it approaches the binding point. Simple as that. So we activate it. We go through the mass of gutta percha until my rubber stopper is 2 millimeters short of the occlusal reference point. And then I remove my finger. As the plugger cools, as the gutta percha cools, so will the descent and the movement of my downpack plugger. Now, what happens to gutta percha when it cools? It shrinks. It actually shrinks about 5 to 7%. So what I want to do is I want to sustain apical pressure on the downpack plugger for 10 seconds to minimize the cooling shrinkage of my apical gutta percha plug. Now, what Kerr has done in their infinite wisdom is they built in a clock in the downpack plugger. So when you release your finger from the activator ring, it counts down. At 5 seconds, you'll hear a single chirp. And at 10 seconds, you'll hear a double chirp. At that point, you've satisfied that criteria for the 10 seconds. And now what we want to do is what's called a separation. Use the mnemonic, 3-10-1. 3 seconds to downpack, 10 seconds. Okay. We'll go back on that. So we lost audio there for a second. So we maintain pressure on the gutta percha for 10 seconds in order to prevent cooling shrinkage. And you'll hear a single chirp after 5 seconds from the unit, and then a double chirp after 10 seconds. At this point, we do our separation burst. Separation burst will allow us to remove the coronal gutta percha from the apical plug. So we activate, deactivate the downpack plugger. We hesitate for a moment as the gutta percha will adhere to the cooling plugger, and then we remove it. We use the mnemonic 3-10-1. 3 seconds for the downpack, 10 seconds for the sustained pressure to prevent cooling shrinkage, and then 1 second for the separation burst. Activate, deactivate, hesitate, remove. So we do canal number 1. We downpack canal number 1. We do the separation burst for canal number 1. Then we go to canal number 2. We do the downpack. We do the sustained pressure for 10 seconds. And then we do our separation burst. Canal number 2, canal number 3, canal number 4. At this point, if you'd like, you can take a radiograph to see if we've achieved our objectives of sealing and corking the apex and sealing any lateral and accessory canals. Now what we do is we do our backfill. We lightly paint the walls of the root canal with some sealer on either a paper point or a stainless steel instrument, and then we take the tip of our disposable cartridge and we just contact the coronal aspect of the apical plug for just a moment. So we heat that gutta percha up. So when we start to inject our gutta percha on the backfill gutta percha will seamlessly integrate with the apical plug. And as we inject our gutta percha, we do it in increments of 5 to 7 millimeters. And as we inject the gutta percha, because of the viscosity of the gutta percha, we'll actually feel our backfill back out of the actual canal. So we inject and we compact. We inject and then we compact. And we back our way out of the canal until we're at the orifice of the canal. And we do this in slow measured delivery. We do it in increments of 5 to 7 millimeters until we're at the orifice. Even if we plan on making a post or making a post space, we want to back our way out right to the orifice of the canal. Because in multi-rooted teeth, you may actually have furcation canals or lateral canals that we haven't sealed on the way down that we may want to seal on the way back up again. Very simple technique. So let's take a look at the video here. And we'll take you through this video. Now, this is available on my website at rootcanals.ca. CA stands for Canada. So we fit our cone in all the canals. We cut off 1/2 to 1 millimeter short of working length to accommodate for vertical movement. We fit our downpack plugger from our downpack device to the binding point. That's the point at which it contacts dentin. Then we adjust our rubber stopper to the corresponding occlusal reference point. Now, in preparation for our backfill, you may want to pre-fit some stopper downpack hand pluggers, sterilized hand pluggers, 2 millimeters short of the working length. So when we are backfilling and we start to condense our gutta percha, when the rubber stopper hits the occlusal reference point, we know that the tip of the plugger is still within gutta percha. Now gently insert all your cones into the canal with sealer lightly painted on the apical 1/3. We sear off all our gutta percha cones at the orifices. And with a sterilized stainless steel plugger, a cold stainless steel plugger, we seat the cone and create that dimple in the occlusal aspect and the coronal aspect of our gutta percha cone. And in one fluid, continuous motion, we take our heat-activated downpack plugger and we go through the mass of gutta percha until the rubber stopper is 2 millimeters short of the binding point or the occlusal reference point. We know the plugger will be 2 millimeters short of the binding point. And then we deactivate that downpack plugger and apply sustained apical pressure on that cooling mass of gutta percha for 10 seconds to prevent cooling shrinkage. Remember, you'll hear a single chirp at 5 seconds and a double chirp at 10 seconds. And then we activate it, deactivate, hesitate, and remove. And with that, we remove the coronal gutta percha. That's canal number 1. You repeat it for canal number 2. Once you've done all the canals, then you apply some sealer, very lightly painted on the wall of the root canal with a stainless steel instrument or a paper point, and then we backfill. Now remember, we'll take the tip of the backfill device, and we will place it and make contact on the occlusal aspect of the gutta percha plug just for a moment and start to inject. And because of the viscosity of the filling material, you'll actually see the backfill device back out of the actual canal. And then you condense it. And then you inject another 5 to 7 millimeters. And you do this until we go right up to the orifice of the canal. So that's canal number 1. And then you repeat the backfill with canal number 2, canal number 3, and canal number 4, all the way up to the orifice. Now remember, in multi-rooted teeth, as I mentioned, you want to make sure that you go right up to the orifice in case there's any furcation canals, lateral canals that you may not have sealed on the way down. Now, one of the things that bothers me is when the restoration of the endodontically treated tooth is delayed. Now, we all understand that patients may not be able to afford the final crown, or the patient needs crown lengthening on a particular tooth, and we want to wait for things to heal. I also understand that you may not want to commit the patient to a crown until healing has been ensured or the sinus tract has resolved, and we understand that. But at least seal off the coronal access. It's really, really important because root canal treatment is not complete until the tooth is restored to function. Now, we want to look at the different studies, and we'll do that in a moment. But what does coronal restoration mean? What does it imply? Well, we want to return that tooth to full function, and we want to create that coronal seal to prevent leakage, into the root canal and subsequently leakage into the periradicular tissues. And of course, we want to return that tooth to full function and protect the remaining tooth structure, especially in posterior teeth. Now, Aquilino and Kaplan came out with their landmark study in 2002, which showed a 6 times greater rate of survival with root canal treated teeth if they were restored with full cuspal coverage. Very important to understand that we need to protect it. And coronal leakage is the bad actor in endodontics. That's how even good root canals fail. And one of my favorite studies was the study done by Trope and Ray at the Temple University, where my alma mater, where I went to school in Philadelphia. And they found that, not only is root canal important, but of course the coronal restoration is important. We'll look at that study in a moment. But the coronal steal, of course, is important, but we have to restore that tooth as quickly as possible, timely fashion, and of course, effectively. So what Trope and Ray did in 1995, it's a long time ago, but the study is very significant, is they looked at the periapical status of endodontically treated teeth in relation to the technical quality not only of the root canal filling, but also the coronal restoration. Now, it was a retrospective study that looked at radiographs. They looked at poor endodontics, and they looked at good endodontics. They looked at poor restorations that were leaking, and they looked at good restorations. And like I said, it was a retrospective study looking at radiographs. Was there success or was there failure? And of course, they found that the highest success rate was where the cases had good endo and good restorations. And they found, of course, the poorest success rate was with poor endo and poor restorations. But what I find very interesting is that there was a higher success rate for cases that had poor endo and good restorations compared to those cases that had good endo and poor restorations. Tavares looked at the French urban population, and they looked at the same thing. They looked at the influence of the quality of the root canal filling and the quality of the coronal restoration on overall success. And once again, of course, the highest success rate were those cases that had good endo and good restorations, and things broke down, of course, when the endo treatment was not adequate, and they also broke down when the restoration was inadequate, where they found a higher incidence of apical periodontitis when the restorations were not adequate. So the conclusions of both of these studies and other studies, of course, was that the quality of the endo treatment was the most important factor for success of endo treatment, but that the quality of the coronal restoration will influence the treatment outcome. It's so important to seal off that root canal system as soon as we possibly can, and then restore that tooth. Close off the system, restore the access, etch and bond, depending on what type of bonding system and composite system you have. We want to seal off that access in order to protect everything we've just done with our root canal treatment. And then the question becomes, do we post or not post? And of course, traditional thought was always thought that, and it still holds true, if you have at least 3 to 4 millimeters of vertical wall, and of course you have that 2 millimeters of ferrule, that's really, really important, then a well-bonded composite or amalgam core was sufficient enough for proper strength and retention of that restoration. But it's that ferrule, and I can't tell you, being an endodontist, the types of cases that we see in our office and how many crowns and how many restorations of full coverage have left their margins on amalgam or composite. We need to have a good ferrule, and that's the bottom line. The importance of it is undisputed. So, although posts don't reinforce teeth, there is a growing body of evidence, 9 studies to date, that fiber posts may actually strengthen the root and make it more resistant to fracture. And, why is a fiber post better? Well, it protects the root, and we know that it has a modulus of elasticity similar to dentin. So the forces of occlusion, any traumatic event that occurs on that tooth will be distributed more evenly over the length of the root, rather than something like a cast post or a prefabricated metal post, which has a high modulus of elasticity, where the forces of occlusion and trauma are often concentrated at the base of the post, at the tip of the post, where root fracture can occur. So rather than having a situation where you have a fiber post, that the fiber post may actually break and may have another opportunity to remove the post and restore the tooth, if a traumatic event occurs with a metal post that has a high modulus of elasticity, the consequences can often be catastrophic, which results obviously in root fracture and then subsequently extraction of the tooth. In addition, metal posts often have that show through where you get darkening not only of the root but also the gingiva surrounding it as well, where you have a light transmitting post, a fiber post, where you don't have this problem, or these problems are obviously minimalized. So in summary, hopefully we presented an evidence-based approach to obturation, continuous wave of condensation rather than cold lateral, though cold lateral works. Warm vertical, according to the studies, has shown, higher success rates, better adaptation to the root canal system, better ability to seal the root canal anatomy, and provide ourselves with that three-dimensional filling of the root canal space. We've reviewed the types of sealers, and in the interest of fair balance, have looked at different obturation units, both downpack and backfill devices that are available on the market, and the most common obturation techniques. Provided you with a step-by-step instruction on how to obturate to full working length, and the ability to go on my website and review the animation that I showed you. And of course, emphasizing the importance of coronal leakage on post-treatment endodontics. And we have to restore that tooth as quickly and as effectively as we possibly can. So if I can hand this over to Mali and answer any questions that you may have to the best of my ability, I will do that. And I make myself available to all of you. You can reach me at Gary, G-A-R-Y, at rootcanals.ca, and have that ability to ask questions, and I usually respond within about an hour. Mali?
Dr. Glassman, thank you so much for that information-filled webinar. It was really comprehensive, and I enjoyed it. I have some questions, but before we get to the questions, kind of review questions, I'd like again to invite our viewers to use the question box in your control panel to ask any questions that you may have, and we will get to them if we have enough time. So my first question is for review. Could you explain again the difference among the obturation systems that you mentioned at the beginning?
The different obturation systems for downpacking and backfilling?
Explain the difference among systems.
Well, the difference is a lot of them are corded. They have cords. The one I like to use, the Elements 3, is cordless. There's the Touch and Heat, which has a very small handle, and it's a Kerr product as well. And it comes with smaller, thinner pluggers as well. So some doctors like to have that, feel in their hands with the small plugger. Narrow posterior plugger is the most common with the Touch and Heat. Some like to use the System B, which also has the ability to, it's a single unit, it's a downpack device. And some like to use a gun, like the B&L, the Beta. And also the Obtura also has a nice gun. And some like the handling of the Calamus as well. So it's really personal preference which system you like to use.
Okay. And to review, what impact does the coronal leakage have on endodontic success?
As we mentioned with the two studies that we talked about, Trope and Ray, and also the one by Tavares, coronal leakage has a significant impact on the success of root canal treatment. Gutta-percha and sealer works in conjunction with a properly timed and effective restoration, but it is a poor biological seal. And until we develop a product that actually physically bonds with predictability to that root canal system, we need to understand and employ good restoration in a timely fashion.
Okay, we have a lot of questions coming in from our viewers now. Let's see. Do you have a preferred sealer for use in conjunction with the warm vertical technique?
I use Kerr Pulp Canal Sealer. It's a zinc oxide eugenol sealer. It doesn't get affected by heat. I've been using it for 30 years, and I've had great success with it. So unless come along with a sealer that is heat stable and works as effectively, I like not to change because it's been working.
Okay, excellent. Let's see who else. How long does it take for you to do one root canal on average?
That's a great question. It really depends on the case. As an endodontist, I don't see clean cases. A clean case is a case that hasn't been touched by a previous dentist, where, I can make my access and not have any interferences of ledges or separated instruments or perforations. So let's take a clean case, an average molar where I can get down to working length. I book usually about an hour. I find the most difficult part of root canal treatment is getting my glide path right to working length. Once I get to working length, everything else sort of falls into place. And there's the shaping, and then the irrigation, which probably I'd say takes the longest, because everything we do up until our final irrigation protocol, like I said, is in preparation for that. That often takes the longest to get there. And then we spend a lot of time irrigating, removing the smear layer, removing that biofilm that contains all the bacteria. And then obturation usually takes the quickest, takes the shortest amount of time. Once we clean it out and dry it, fit in our cones, and then downpacking backfill usually takes the least time. So I'll usually schedule an hour. It may not take me that long, or if I find that, I run out of time, then I'll place a calcium hydroxide and bring the patient back for a second visit.
Okay, next. What is the best ratio of fiber post versus gutta percha remaining?
As far as leaving gutta percha in the apical 1/3, well, anywhere between 4 and 7 millimeters is usually the standard to leave at the apical 1/3 to place your post in. Now, of course, because the post is being bonded to the root canal wall, we're not counting on physical retention like we are with cast posts and cores or prefabricated metal posts. We're actually bonding it. You require less length. But as long as you have about 4 to 7 millimeters of apical seal, then that's usually current thinking.
Okay, the next question from our viewers are having so many questions. This is very exciting. What is your rate of overextrusion of GP with your technique, understanding that you do try to compensate for this by cutting the cone short?
Yes, so that's a great question. If you've got good tug back, and after doing, thousands of cases, my rate of extrusion is very, very low. Listen, sometimes we do. Sometimes we miscalculate where our tug back is, and we end up getting tug back higher up than the apical 1/3, and when we downpack, we end up, extruding it past. But very low. I can count on, one hand the amount of extrusion of actual gutta percha cone I've had in the last, I'd say, couple years. Now, I do get some sealer coming out, the apex or lateral canals. We do get that, what we call the shoulder puff, or the puff of sealer, which I don't mind. But actual gutta percha cones coming out, very, very low incidence, as long as you have a well-fit cone.
Okay. Person said, please shed some light on the gap between sealer and GP.
I don't follow that question.
I'm not sure what that question means either. If the viewer wants to do a little bit, send another question and be a little bit more specific, we can go on so we don't waste time. Do you retreat a non-symptomatic bad root canal?
Okay, well, that's a good question. Remember, we treat patients. We don't treat x-rays. We get lots of cases coming in from Eastern Bloc countries where the root canal treatment has been maybe halfway down the canals and there's no symptoms. It's asymptomatic. Do we treat them just because it doesn't look nice on an x-ray? No. If a patient has a poorly done root canal and they're going to be getting a crown done and we see there's leakage, decay, etc., then perhaps we will retreat that case. But just because it doesn't look nice on an x-ray doesn't mean we have to go and retreat it. It's case specific. We can't just, give a blanket statement of yes, we do, or no, we don't.
That's a very good answer. Understanding how important the coronal seal is, do you place any composite before temporizing your tooth?
Before temporizing the tooth, I see. So before I send it back to my referring dentist. So what we'll often do is we'll put a layer of glass ionomer over top of the pulp chamber floor and over the orifices of the gutta percha cone. Some docs like to use a cotton pellet. Some like to use plumber's tape, Teflon tape, and just scrunch it up and put it over there, and then over top of that, and then put the temporary filling on. So we have a the plumber's tape, and we have an extra layer of glass ionomer. And it's very easily removed by ultrasonics when the referring dentist wants to restore the tooth. Now, I do restore probably about 25% of the teeth that I do root canal treatment on, where the restoration isn't too complex and I feel comfortable doing the restoration, then I will do that, because the best time to restore an endodontically treated tooth is at the time of obturation.
Okay, next. You mentioned bioceramics gaining popularity. Why is that? And do you foresee any potential drawbacks down the road since there aren't any long-term efficiency studies yet? Yeah,
well, bioceramics seem to be hitting the obturation scene by storm, and they contain calcium silicate, MTA, mineral trioxide aggregate contains calcium silicate, and the ability to recruit the body's cells to affect healing seems very, very exciting. From my knowledge of bioceramics, they're often used with a single cone technique because they may be unstable with heat. But from what I understand of my colleagues in the university scene that are doing a lot of research, they're working on the heat stability with that. And if they can control that and maintain a stability with the application of heat, it's probably going to turn my head and have me probably switch sealers. But until then, I'm going to stick with what I'm comfortable with, and others will stick with what they're comfortable
with. Speaking about that, you mentioned cut back 0.5 to 1 millimeter of apical portion of gutta percha. Can we just use a gutta percha that has a good tug back 0.5 to 1 millimeter short of working length?
Sure. I mean, if you're cleaning your root canal and debriding it adequately, and you're 0.5 millimeter short or 1 millimeter short, I could live with that. I like to be right at my apical terminus, so that's why I like to cut it back, and I like to cork the apex. So that's my comfort zone. For those that were within 1 millimeter or 0.5 millimeter, man, if I were within 0.5 millimeter and 1 millimeter for every one of my cases,
I hope I can hear you. I think you just cut out a little bit, but the final question that I have here is, which temperature do you set when performing the backfill, 200 degrees or 100 degrees? I think we lost your sound. Can you try it again? Well, I think we did lose our sound a bit, but actually we also have run out of time. So it's actually time for me to thank everybody for your questions. And the one that we did not get to today, we will answer after the webinar via email. So please remember to take our free CE quiz associated with this webinar. Shortly, we're going to send you all a recording of this presentation and instructions on how to access the CE quiz. So look out for that and take the quiz and get your credit, and that'll all be good. Thank you all again for attending. The special thank you to Dr. Glassman for your wonderful job. And we also thank our sponsors. Oh, there you go. Your sound is back. And
we're back.
Do you want to answer that question? Which temperature do you set when performing the backfill, 200 degrees or 100 degrees?
I do 200 degrees Celsius.
All right. We answered all our questions. But we have a special thank you to our sponsor for this webinar, Care Endo. Thank you and have a good evening. We'll see you next time.
Thank you.